Welcome to the first presentation in our speaker series for the Ohio University Summer REU program and the RISE program at Nationwide Children's Hospital. The first presenter is Dr. George DuPaul, a professor at Lehigh University, and this presentation was done on June 5th, 2024. We joined Dr. DuPaul's talk about 1 minute into his presentation.
But also on, and perhaps more importantly, as a priority, on improving functioning in the academic, social, or in the case of adults with ADHD, the occupational domain. As you may already know, ADHD typically is identified early in life, usually by early elementary school, and it also tends to be chronic throughout the lifespan. It affects a pretty significant percentage of the population, anywhere from 5 to 10% of the population. Actually, some recent data from the CDC would indicate, based on parent report, that up to like 12% of youth in the US currently have a diagnosis of ADHD. So that's obviously a significant percentage, particularly if you think about from a school perspective, classrooms. A typical classroom will have anywhere from 20 to 30 students in it. So what that means is that every classroom is going to have at least one student with ADHD, if not more, in that classroom. It also differentially affects males relative to females, a 2-to-1, 3-to-1 ratio, depending on the population or age group you're looking at. The most typical treatment, as I'll show you some data in a minute, is stimulant medication, particularly methylphenidate and methylphenidate derivatives. It's also a costly disorder, and this is based on older data now, back almost 20 years now. But in $2,005, the annual societal cost in the U.S. for childhood and adolescent ADHD is over $42 billion. And of course, with inflation, that's going to be much higher these days. So it's not a benign thing. It is significantly impairing and is chronic, and therefore requires intervention that is applied over long periods of time, typically in some cases over the lifetime. In terms of evidence-based interventions for children with ADHD, the good news is that we have a good menu of effective interventions, including medication, which primarily impacts symptom reduction, is what primarily occurs with psychostimulant medication in particular. So that means improved attention, improved impulse control. But we also want to supplement medication, as I'll talk about later, the need to go beyond medication for helping youth with ADHD. We want to work with parents and teachers to use behavioral strategies at home and in the school. A lot of good data to support the use of those methods, particularly for children, elementary school age children, and preschool age children with ADHD. There's also some evidence to support the idea of behavioral peer interventions. So not necessarily social skills training per se, but targeting, identifying social behaviors that should be displayed in a peer context and reinforcing those behaviors as they occur. So again, applying behavioral principles to peer situations. Academic support, so direct academic instruction that directly relates to the areas of weakness that students with ADHD may experience. And then for middle school, high school students, organization skills training and other multi-component training programs to provide the skills for those individuals to succeed in school. I'm going to emphasize school throughout. I'm a school psychologist, obviously, and a lot of the research that I do is either happening in school or is focused on enhancing success in school. Because, as I mentioned to you on the previous slide, most individuals with ADHD experience academic impairment of some sort, and as a function of that, may be at higher risk for being retained in grade, higher risk for being placed in special education, higher risk for dropping out of high school, and less likely to go on to post-secondary schooling, and of those who go on to post-secondary schooling, less likely to graduate from college. So there's a significant academic impairment component associated with ADHD. So that's where a lot of my focus has been along with my students and colleagues, to try to address that impairment directly. And this just gives a kind of an overview of some of the themes of the ADHD research that we've been conducting at Lehigh with the lab that I've been fortunate enough to work with over the past 30 years now at Lehigh. And I've highlighted 4 areas. 2 in particular are in red font because in the interest of time, I'm not going to be able to cover everything. So I'm going to focus on two areas in particular. So some of the questions that we tried to address are, what can we do to help young children at risk for ADHD to be ready for school? We know that 3, 4, and 5-year-olds with ADHD or who have ADHD symptoms, they may not be diagnosed yet. They're going to enter elementary school behind their peers in terms of behavioral self-regulation, as well as in terms of early academic skills. So we've developed a behavioral parent training program. That's what BPT stands for caregivers of young children with ADHD. So I'm going to talk a little bit, give you more detail about that in a few minutes. If we look at the next developmental stage, elementary school, my colleagues and students and I have done research to try to identify how we can improve academic and social functioning in elementary school, primarily in terms of working with teachers or with classmates and peers to deliver interventions that help support academic and social functioning. And we also have conducted a couple of meta-analyses to look at the effects of various interventions for elementary school age students with ADHD. And a couple of things, I'm not going to have time to go over the meta-analyses in particular, but a couple of things I want to highlight from that work. One is that behavioral interventions in particular are not only statistically significant in terms of improving functioning, but also result in at least medium effect size change. And by effect size change, I mean standard deviation, about 0.5 standard deviation units of movement, of improvement, if you will, in behavioral functioning. We also found through those meta-analyses that if we directly target academic impairment, that not only results in significant effect sizes, usually of medium magnitude, in terms of academic performance being improved, but that behavior also improves, which is interesting. So if we target impairment and we target functioning areas directly, we can get symptom improvement as a secondary effect, which when you think about it kind of makes sense, right? If a student is doing better academically, so they're getting more work done, they're performing better, their work is more accurate, it's very likely that they're paying attention, right? And that they're following classroom rules in order to be able to complete the work and complete it accurately. So I just want to mention that as one of the big ideas that I want to emphasize today is that we really need to be thinking about, as we develop interventions for youth with ADHD, that we should go beyond symptoms and target the areas of impairment, not only because those are important to improve, but they can also result in more bang for our buck in terms of not only improving the academic performance in this case, but also behavior control, which, by the way, the reverse is not necessarily true. In other words, if we improve behavior, that doesn't necessarily guarantee that we're going to get improved academic performance unless we're directly addressing the skill deficits that the child has. If we move to the next developmental phase here, middle and high school students, along with Drs. Evans and Owens at OU, been fortunate to collaborate on a study that I'm going to talk to you about in a few minutes that answers the question, how can we help middle and high school students with ADHD succeed in school? And that will be a focus on multi-component skills training, organizational and study skills training with the Challenging Horizons program. And again, I'm not going to be able to get to it today, but I've also done research on how do we help college students with ADHD. I haven't really done much in the psychosocial area there, but I was part of a group that investigated medication effects for college students with ADHD, in particular a controlled research study of stimulant medication called Vyvanse. And because I won't have time to really talk too much about it, I'll give you give you 2 bottom lines from it. One bottom line is that Vyvanse did definitely, for most of the college students who were in the study, was significantly better than placebo in reducing self-reported symptoms of ADHD and increasing self-reported study skills. But the other takeaway from this is that the improvement was still not normalizing. In other words, college students with ADHD tend to have lower GPAs, have lower academic performance than their non-ADHD peers. Vyvanse helped to bridge that gap to some degree, but there still was a gap, even with the best available dose for any individual student. The medication did not get them fully to the point where they were performing at the same level as their peers, which you would take away from that as indicating that they need more help beyond medication and more assistance around their study skills, more assistance around academic challenges that they might experience. So medication alone, effective to some degree, but not fully effective, and therefore necessitating further treatment. So let me talk about the two studies that I've highlighted here in red. Well, before we go there, as a lead in to the first study around behavioral parent training, these are treatment data from Blue Cross Blue Shield insurance company, national data from a few years ago, almost 5 years, well, more than 5 years ago now, 2019. And what you see here are data in terms of the percentage of patients in the Blue Cross database with ADHD who are receiving various treatments. And so the top line here is showing that about half or a little more than half of those patients were receiving ADHD medication by itself. So no other intervention, just medication, which, as I mentioned to you, is rarely sufficient, particularly for addressing impairment. About a quarter of the patients were receiving both medication and behavior therapy within the same year. So 1 out of every 4 were getting the combination of medication and behavior therapy, which, by the way, is often recommended as the optimal treatment plan, the combination of medication and behavior therapy, but only 1 out of 4 were getting that combination. And then only about 10% of the patients were receiving behavior therapy alone. So if you combine these two figures, 27%, 12%, you have about 39%, so roughly 4 out of 10 patients who are getting some degree of behavior therapy. And that's problematic for a couple of reasons. One, again, we don't want to rely on medication alone. It's not sufficient. And then secondly, many of the organizations, American Academy of Pediatrics, for example, recommend behavior therapy as a first-line treatment, particularly for younger kids, preschool and elementary age kids with ADHD. And from these insurance data, it's very clear that there's the majority of ADHD patients are not getting behavior therapy, not only not getting it initially, but not getting it at all. And why is that? One of the factors that is probably related to that is access to behavior therapy. That's not generally accessible in all parts of the U.S. Rural communities, for example, less access to behavior therapy. Also, there may be an affordability issue where families don't have access to insurance to cover behavior therapy, or their health insurance may not cover it, even if they have insurance. And so access is a big issue. So as a function of that, we wanted to develop a way to look at how we can increase access to BPT without sacrificing efficacy. There's very large research literature to support behavioral parent training for ADHD, particularly, again, for young kids and elementary age kids. But again, as I showed you with the other data, the majority of families don't have access to that efficacious treatment. So my colleagues and I, chiefly Lee Kern at Lehigh University, we developed a parent education and behavioral parent training program called PEAK, which is promoting engagement with ADHD pre-kindergartners. That's what PEAK stands for. One thing you always want to think about as you create your research program, you want to have a good acronym and you want to have an attractive logo. It helps with the marketing and the recruitment and the communication around the research program. Anyway, we developed a 10-session program that has many of the common features that you will see in most behavioral parent training programs, focusing on preventive teaching and response strategies that can be applied at home and in the community. But we added to that psychoeducation around ADHD. We also include a session that's focused on supporting early literacy and numeracy skills, because as I mentioned, young children with ADHD can enter elementary school significantly behind in terms of early academics. And we also include a session that focuses on parent self-care, and we integrate throughout what's called optimistic parenting, where we're helping the caregivers to identify negative cognitions that they have and negative beliefs that they have about their parenting, helping them to identify and be aware of those, and to engage in various strategies to reduce those pessimistic thoughts and to be more optimistic and focusing more on the positive outcomes of their parenting and their parenting skills. So we've integrated that with the behavioral strategy instruction. So what I can tell you about, what we have data on, full data on so far is a pilot of the PEAK program in a randomized trial that was supported by the Institute of Education Sciences a few years back. And this is a small sample pilot study. We had 3 conditions that we looked at, and this is directly related to the access question. We have face-to-face delivery of BPT, which is the typical way that it's delivered. Families travel to a clinic or other setting, meet in a group with a therapist who works for them for, let's say 90 minutes a session, and then they go back to their homes. That's the traditional way that BPT is delivered. We developed an asynchronous online version of PEAK, the exact same content that we would deliver face-to-face, but in that condition, parents and caregivers could get access to the content online at their convenience, and on they can participate in a little bit at a time, or they could sit and go through the whole session. There was a lot more convenience related to that, and certainly less cost in terms of travel, childcare, et cetera. There was also a waitlist control group, so participants were randomly assigned to these 3 groups, and we wanted to see essentially whether online BPT leads to equivalent outcomes or non-inferior outcomes, if you will, to traditional face-to-face behavioral parent training. And I'll just show you a couple of outcomes really quickly in the interest of time. One of the important outcomes that we're focused on as a proximal outcome of BPT is increasing parent knowledge of effective intervention strategies. And what you see here is just a percentage correct on a survey around or survey of possible intervention strategies, higher scores being better. And so we have a face-to-face improvement pre to post, and a very similar parallel line, not quite as high, but not statistically significantly different for the online parents. And then the waitlist controls, just a modest increase from pre to post. And this difference at post-treatment was statistically significant between the 2 active conditions, which were not different from each other, but both were significantly different from the waitlist control. So that proximal outcome of increasing knowledge was obtained. We also looked at, we sent research assistants to the homes of these families and observed parent-child interactions and the degree to which parents were actually applying the intervention strategies with fidelity. And again, you have the same result here at post-treatment, where the 2 active conditions were significantly better than the waitlist controls in terms of fidelity and implementation of the recommended intervention strategies. And the 2 active conditions were not significantly different from each other. So establishing, in this case, non-inferiority in terms of that outcome. And then ultimately, we want to get changes in child behavior. This is one subscale from the Connors rating scale that parents completed pre and post. and is focused on restless and impulsive behaviors, so the hyperactive impulsive component, which tends to be the most dominant set of symptom features for 3, 4, and 5-year-olds who are identified or at risk for ADHD. It's that hyperactivity, impulsivity that sets them apart. And again, what we see here is a pattern that we've showed with the other outcomes, significant reductions in this case of parent-rated restless impulsive behaviors for the 2 active conditions, with statistically significant differences here at post-treatment from the waitlist control group. I do want to point out that these are standard scores. The scores above 60 are, above 65 are considered clinically significant. So even though there was improvement at post-treatment, the scores were still above the clinically significant cut point, implying that further support is going to be needed for these families beyond the 10-session intervention. We're currently in year 4 of a 5-year larger scale randomized controlled trial. I'm just going to mention a couple things here, just in the interest of time. We're getting a larger sample so we can get more reliable data. We're looking at cost and cost effectiveness across the 2 platforms. It's the same, by the way, the same design, where we have an online, asynchronous online group, a face-to-face group, and then a waitlist control group. The waitlist controls get access to the online program after a year. So again, families are randomly assigned to one of these 3 conditions. We're looking at, again, relative costs and cost effectiveness across these groups. We're also going to be able to look at maintenance of effects across 24 months post-treatment. So we collect pre and post data, followed by 6-month, 12-month, 18-month, and 24-month maintenance data. And we're also going to be able to look at mediators and potential moderators of intervention effects. We're not fully powered for that with 180 in our sample, but it's at least going to give us an opportunity to estimate effect sizes around mediators and moderators. So the other study that I want to talk briefly about, jumping to the adolescent age range, is focused on this question: how can we help teens with ADHD use strategies to improve school functioning at the point of performance? I haven't mentioned that concept up to this point of performance. I do want to define that for you. The point of performance refers to the time and setting where a specific behavior is desired or is being sought. So, for example, with students with ADHD, we want them to be engaged with instruction and to be doing accurate work and participating in class activities appropriately during specific academic classes. So those would be various points of performance. And it's kind of a general rule around interventions for individuals with ADHD that the best interventions are those that are applied at the point of performance, at the time and in the setting where the behavior of interest should be occurring. With adolescents, we're hoping to give them skills that will put them in position to engage in strategies that will result in better performance at that point. So this is an overview briefly of the Challenging Horizons program at the high school level. Challenging Horizons program was developed by Dr. Evans for middle school use. Multiple studies showing efficacy of both after school and school-based CHP for middle school students with ADHD in terms of improving organizational skills, academic grades, and associated behaviors. Dr. Evans and Owens and I worked together on a grant that was supported by IES, Institute of Education Sciences, to develop and apply this for high school students, 9th, 10th, and 11th graders with ADHD. And you can see that there are multiple components here: organizational skills, problem-solving skills, academic skills, including preparation for exams, interpersonal skills training, as well as engaging parents in a homework management plan. I'm looking at the time here. I'm not going to be able to go through all the details here, but I'm going to run down some of the major give you an overview and some of the major findings. We had a randomized controlled trial, including 186 participants. who were randomly assigned to either active CHP for one school year, so it would go through the entire school year from September to June, or they were randomly assigned to what's indicated here as community control. So in other words, they had access to interventions as usual, either in the school or in the community or both. I won't run down the demographics here, but you can see that relatively diverse sample, given the areas of Pennsylvania and Ohio that we were recruiting from. And we had multiple outcome measures, including ADHD symptoms, social skills to improve, looking at improvement in social skills, as well as improvement in organizational skills and homework. We had collected data from the students' report cards about the grades that they were receiving at each of the 4 quarters of the treatment year, as well as the 4 quarters for reporting periods for the follow-up year. And I do want to point that out. We collected data pre-treatment, mid-year, end of the treatment year, and then 6 months later in the following school year. So we're looking at both immediate post-treatment outcomes as well as follow-up. I'm going to skip over that slide. I'm going to skip over that. This gives you a rundown of the many of the outcomes where we found statistically significant effects, both at post-treatment and follow-up. I want to emphasize that. And in many cases, the effect sizes, which are represented by these Cohen's d effect sizes, which are change in standard deviation units. So for example, here we have a 0.5 Cohen's d indicates a half a standard deviation difference between our community care control kids and the kids that got CHP, which is considered a medium effect size. It's actually a larger effect size than we got at post-treatment for inattention. And that's kind of the pattern for several of these things, particularly the parent ratings of social skills and organizational skills. Let me show you, we didn't get universally significant findings. There weren't significant effects on teacher ratings, which there's a whole host of reasons why that potentially occurred. You can consider GPA as a teacher rating of sort. It's a high, high impact teacher rating because, report card grades obviously have, a lot of impact on kids functioning, and essentially it's teachers' views based on their performance in the classroom. So this really kind of takes the place in some ways of teacher ratings in terms of importance, certainly. This just shows the pattern of change in the community care group versus the CHP group out to 6-month follow-up on parent ratings of organizational skills. Lower scores are better. And what I wanted to show you was the grades data. This is on a 0 to 4 GPA scale. So 4 being A, 3 being B, et cetera. And we have, we consider, a B average to be, relatively successful. That's where we want to be for most of our students. Line represents the CHP students across time. The reporting periods initially here for first, second, third, and fourth quarter of the treatment year, followed by the first, second, third, and fourth marking periods of the follow-up year. The dashed line are the community care control groups. And what I want you to do is just look at the treatment year. So up to this point here, treatment year quarter 4. What you see here is a typical pattern when you look at the community care control students, that typically for high school students with ADHD, their best marking period is the first marking period. And there may be a honeymoon effect or a carryover effect from the previous year. But then there's steady decline in performance over the course of that year. The good news here was CHP protected against that drop for the most part. So it didn't necessarily lead to, a linear increase in GPA, but it was protective in terms of that significant decline and over the course of that treatment year. Unfortunately, that did not maintain in the following year. You can see that drop off from the first marking period and the follow-up year, both groups had a drop-off at the second, third, and fourth marking periods, so they were no longer different. And that implies that at least when we're thinking about high-stakes outcomes like grades, we probably need to be thinking about extending CHP into succeeding years, or at least providing some booster support for at least some students who might be at risk for experiencing this decline in GPA across time. So I'm going to finish up here and just highlight a few things that I've tried to emphasize, some of which I haven't gotten to emphasize, but I will now. Out of this intervention research, again, focusing on translating research to practice, there's several things that I would want to emphasize. One is that we should be prioritizing as we conduct these studies and as we work with students and their families in practice settings, we should be prioritizing improved functioning over symptom reduction for two reasons. One is many times that's what families and students are most concerned about, their academic and social functioning as opposed to their symptoms. Secondly, there's good reason to believe that, at least in some circumstances, when we target improved functioning, symptom reduction follows. The reverse is not necessarily the case. We see that with medication, for example. Medication leads to significant reductions in symptoms, but not necessarily concomitant improvements in functioning. And that leads to the second bullet point, which is medication alone is rarely sufficient, especially for supporting functioning, as I've mentioned. When we're thinking developmentally here for preschool and elementary school age children, the primary therapists, if you will, are the parents and teachers. So our role is to support parents and teachers in delivering efficacious behavioral and academic interventions at the point of performance. So at the time of day, in the setting where the behavior of interest is occurring. That's our focus. With adolescents, we need to work with them. We need to partner with adolescents at that stage in middle and high school to help them develop the skills around organization, study skills, social behaviors that they can then apply at the point of performance, because as adults, we're not going to be in every setting, every important setting with adolescents as we might with children. And then the last thing that I want to emphasize here is that we have a vast opportunity in our field to leverage technology to increase access to efficacious intervention. We have interventions that we know work. The problem is getting them to be used in a consistent and accurate way in the settings where they need to be applied: home, school, and community. There's a pretty large gap there between the research evidence and the actual practice that we see in schools and homes, et cetera. And we're living in an age where there are vast improvements and advances in technology. I think we're all aware of those that can really help with access and help with encouraging parents and teachers and students themselves to be using strategies that we know to be effective. So I'm going to stop there, and I'm going to go back out here and stop sharing and open it up. I apologize. I think I went a little bit over time here, but looking forward to any questions or comments that you might have at this point for me.
Should we just do this?
So to facilitate doing this in an organized manner, if you see, those of you not familiar with Teams, there's a little hand symbol at the top of your screen with a word raise under it. Just raise your hand there and I'll call on people to facilitate the question and answer period. Yes, the RISE block.
So we have one hand for 10 people.
Okay, that's fine.
Really cool presentation, George. I have two, if I can be greedy. One is a super nerdy technical question in the weeds, and the other is a more big picture one. Would you like big picture or weeds first?
Let's start in the weeds.
So several slides back, you had significant quadratic and cubic effects on the time analysis of grades. I so rarely see people look at those, and even more rarely see them be significant. And I wonder if you have a cool way of describing what that is, something that reviewers would be like, oh yeah, I get it.
Yeah, no, that's great. Great question, Eric. Yeah. So the challenge is we had 9 data points, right? So we had the cumulative GPA for the year before CHP. And then we had 4 marking periods in the treatment year, 4 marking periods in the follow-up year. And, ideally, it would have been great if there was a linear separation, right? And just CHP universally, increasing or steady state and decreasing on the community care
And
control
rainbows
side.
and unicorns and butterflies.
Exactly. That did not happen. What I think is even more interesting and perhaps telling is what the the quadratic and cubic picks up is the change in direction of the lines over time, and I believe reflect what I had described, which is that we had one set of effects during the CHP year that was protective, and didn't necessarily lead to a linear increase, but protected against the decline we saw in the community care control group. But then the follow-up year, that difference went away. We had again some changes in direction of the trajectories there as well. So I'm not sure if I'm explaining that helpfully, but that's the way we interpreted it, is that we have a number of changes that are occurring in the direction of the trajectories, where we have some divergence during the treatment year and lack of divergence in the maintenance year, which we interpreted as showing, yes, CHP can be protective while it's being implemented, but in order to retain that protective effect, or perhaps even enhance or result in even greater improvement in GPA, we probably need some booster support or additional CHP intervention in the succeeding year.
It was cool SlideCraft having that slide, and then the visual of here are the trends as the observed points, and so that one too really was neat, and it definitely, it was good to not just see smoking rubble with no significant linear effect, but to have an effect that you were able to document.
Yep.
I would just add that I think the longer term studies, like this was a 2-year treatment study, which doesn't really happen very often, but the longer your period of time, the more you should look for quadratic and cubic and other nonlinear effects, because you're covering such a long period of time. Change in trajectories are likely.
And the other thing I would add, Eric and others, is I didn't report on it today, but we did some follow-up analyses where we identified latent trajectory subgroups of students who receive CHP, and we were able to identify 2 groups in this GPA domain, where we had some students, thankfully a smaller minority of them, who didn't really respond from a GPA perspective, and showed that declining trajectory that we saw in the community care group. But we also saw about 70% of the CHP students showed improvement with the GPA, showed a trajectory of improvement.
Is that published?
Yes, it was just published a month or 2 ago in Behavior Therapy.
Could you slide me a PDF?
Sure.
That would be awesome. I've done, yeah, that I'll just leave it at that and give the mic to somebody young.
Alicia?
Yeah, I was thinking, like Dr. Evans was saying, like it was a 2-year study. I was curious about the retentions between the groups and if there was like a difference in retention rates and how that may have affected your results.
It's an excellent question. Our retention was quite high. I don't remember the percentage off the top of my head. I don't know if you do, Steve. But we were fortunate to have not necessarily 100% retention, certainly, because we had some students who dropped out because they moved out of the area primarily. But it was over 90% retention. So we did actually some analyses to see, you know, whether retention was an issue for us analytically, and fortunately it was not. But that's a really good question. Certainly in any kind of longitudinal study like this, that's something that you have to be concerned about.
Thanks, Alicia. Hannah?
All right, we got a question in here. Hi, Dr. DuPaul. Thank you for the wonderful presentation. I do have a question that's kind of thinking about how to expand the broad, like expand the CHP program. I was thinking about, because you talk about mostly in terms of children and adolescents, I was thinking about whether there are effective intervention beyond K-12 education. And I was thinking about in university or colleges, because at that time, parents may not have that kind of influence on children and adolescents as compared to when they are younger. And also, is there intervention that is for children or adolescents that's not diagnosed with ADHD, but have symptoms of maybe hyperactivity or intention issues? Yeah, thank you.
Yeah, both good questions. So with the college students, you've identified a really important question that I think has only been recently investigated. That is interventions beyond medication for college students with ADHD being subjected to any kind of controlled study. I have not directly participated in any of those studies, but have colleagues, Arthur Anastopoulos and Josh Langberg, completed a study just a few years ago on a program that they called Access, ACCESS. I don't know what that stands for, but as I mentioned to you earlier, you always have to have a good acronym for your program. So it has something to do with college students with ADHD. But anyway, it's a program that's kind of an expansion of CHP at the college level, if you think about it that way, because it's focused on helping college students with ADHD in terms of their study skills, their organization skills, their social integration into the college community. Also has a cognitive behavior treatment component to it of helping them to recognize irrational cognitions around their performance and helping them to recognize those cognitions and modify them in the hopes of also modifying behavior. And it involved they conducted a randomized trial of Access in multiple universities in North Carolina and Virginia, and had really strong effects. When I say that, I mean, medium and to some case large effect sizes on primarily self-reported outcomes. So you have to take that into account, that it was based on primarily college student self-report. But they've published those findings. I can try to send a reference to you and the group around that if you want to follow up on that. And I believe they're in the process of a book maybe coming out that's based, kind of the manualized intervention book on the Access project. You also asked about, how do we help kids and adolescents who may be symptomatic but not diagnosed. We haven't investigated that specifically, or at least I haven't, but I have no doubts based on the data we have, as well as the anecdotal evidence, that the interventions that we applied, whether those be behavioral parent training in one case, or younger kids, or CHP with middle and high school students, that one does not have to be diagnostically identified in order to profit from these interventions. In fact, you could make the argument that almost all students could benefit from at least some of this support. So I don't know if my colleagues have additional thoughts about that, of these interventions being applied to youth who have not necessarily met the diagnosis of ADHD, but again, I'm really confident that they would be effective for those individuals as well.
I have follow-up questions. The at OU or where you are, George, or do the clinical programs or the school psychology programs talk with CAPS or the student services or clinic? Do the grad students do rotations there? Do
Yes.
people do research there? Is that how strong are those ties?
At Lehigh University, Eric, they have graduate assistant positions in
Yep.
their in the student disabilities office and in the peer, I forget what they call it. It's essentially peer coaching office. It's not called that, but something along those lines. And very often our school psych students, some of whom from my research program, end up in those graduate assistant positions. So they're in a position of providing coaching and tutoring and other supports to not only students with ADHD, but students with learning disabilities and some other disabilities as well. We haven't been doing any, we did collaborate with our student disabilities folks to do a large scale longitudinal descriptive study of various areas of functioning for college students with and without ADHD. But I have not collaborated with them around any intervention studies to this point.
What about at OU?
We have students who do placements in the counseling program, student counseling program, but as of yet, I don't think we have, other than having done, Brian and I did a workshop for the student coaching staff or whatever they're called, but we haven't had a lot of active collaboration with them. And we don't have a school psychology program.
At Carolina, students would could do a rotation there, and so there was like a connection with the clinical training. Sometimes there was one person there that was really excited to work with me on research, but then they retired, and that was kind of the end of that. And so there's like almost no crosstalk even within the same institution. And as I was listening to Noreen's question and George's answer, I'm like, we're all sitting inside a children's hospital. And so there's like a ton of ADHD coming in the door. But then a conversation that we're having here is what happens when they turn 18. My daughters are 23 and 25, and one just finally let go of her pediatrician. So like pediatricians are like we'll keep you a little bit longer if you're if it's a good working relationship, but at some time you got to let go. And I realized I have an appointment at OSU, but I've had no conversations with the clinic at OSU. And I don't, is there any, I'm going to ask an awkward question. Is there anybody at OSU that's doing ADHD research?
Not that I'm aware of.
Yeah, not that I was aware of either. So there isn't a natural ally in the research area.
Right.
So this is sort of a gap. Listening to Noreen, I'm like, ooh, that's a really important gap. You guys all get it because you're all freshly out of college or still in college or university. So like you're like, yeah, is anybody thinking about this gap? Is anybody working on it? And I'm like, oh, snap.
Yeah, another thing to put on your list, Eric.
Awesome.
Julie, I see you raised your hand.
Yeah, just in response to Eric, this isn't at the college level, Eric, but we are submitting an R34 for elementary school enhancements to ADHD school-based care with Nationwide Children. So you might be aware of that with Mary Freistad and some of our other former student clinicians.
I've heard rumors from Mary.
Yeah, so that's cool. And then I also just wanted to say, George, I put in the chat too of Art and Josh's main outcome papers from the assist, if folks want to take a look at the chat.
Oh, thank you. Did I get the acronym wrong? It's ASSIST?
No, sorry, it is access. I was thinking about assist, something else. It's access, sorry.
Yeah. Yeah, no, thanks for putting that in there. It's, Eric and others, it is a, I think back to, I've been at Lehigh 32 years now. When I started in the 90s, the Student Disabilities Office was a part-time psychologist. And almost all of it was a very limited number of students at Lehigh that were identified with disabilities, and it was primarily learning disabilities. And then over the course of time that I've been at Lehigh, that office has exploded. There's now, I don't know, 4 full-time people in there. And the number one disability on campus now is ADHD, with autism catching up, and LD still there, learning disabilities. And we don't have as much work as we all have done in the preschool, elementary, middle, and more recently high school domains. The college student ADHD support research is a vast wasteland right now, other than, Art and Josh's work and a few others. In terms of that, focusing on the academics, focusing on the social functioning, we need to be it's a growing segment of the college population, and it's these offices are usually under fire to provide services that sometimes aren't all that efficacious, like accommodations, for example. They spend a lot of time identifying potential accommodations, and as Steve and others have demonstrated, accommodations have very limited efficacy, if any efficacy. And so it's this next generation of researchers, as represented by this group today. That's an area, if you're really interested in that age group and that setting, there's a lot of opportunity there to make a difference with research.
Thank you. And I see, and I apologize if I mispronounced the name, Kanadi. Is that close?
Hi, it's Kennedy.
Oh, sorry.
No, it's okay. I get it a lot. Um, so my question was, how are you able to distinguish your research from similar research, and what advice would you give us when distinguishing ours from similar research?
That's a really good question. I think there's certainly a substantial overlap of my work with colleagues elsewhere, including some of the folks here in this meeting. And I think that's a good thing, right? Because it builds collaboration. It builds potential to do larger scale studies across sites. It's exciting in terms of getting different ideas in different contexts. That said, all of us as scholars have to develop our unique niche, right? So our unique trajectory and unique focus on our research. And I feel where mine has been somewhat unique, at least in some respects, is around the focus on academic functioning of individuals with ADHD, and developing assessment measures around that, as well as interventions to support improvements in those impairments. And also the focus on interventions from a school psychologist perspective, and that is, how can school psychologists as school-based mental health professionals support students with ADHD and related disorders? I feel like, that's been a somewhat unique aspect of what I've been doing, but I don't know that any of us can be 100% unique, right? But we do need to identify where our niche is. And I think most importantly, what we would want to focus on as an early career professional is yes, we want to build our unique direction, but we really need to ground that in what does the community need, right? We need to be conducting research that's going to directly impact the needs of the community and the practices that are going on in the community. And so long as we can develop a line of research that can inform community-based practice in an effective way, we're going to have success as scholars.
Thanks, George, and thank you, Kennedy. I don't see a hand, so I'll throw out one I think may be relevant. If I'm somebody who wants to do clinical treatment-oriented research in my career for children and adolescents. I can't decide whether to go into a school psych doctoral program or a clinical psych doctoral program. What kind of things should I think about to inform that choice?
Okay, put me on the spot there. Thanks, Steve. Appreciate that question. Actually, it's an excellent question. I don't mean to take it lightly. It's an excellent question. There is a lot, in my view, there's areas of overlap in training and research orientation between school psychology and clinical child psychology. And that's something, again, that I've seen over the course of my career, is that kind of growing convergence, if you will, between those two disciplines. I think that where an undergrad or aspiring graduate student should be thinking is, where do I ultimately want to end up? What do I ultimately want to end up doing in my career? So some of the questions to think about there are, what populations do I want to work with, whether it be research, practice, or both? And in what settings am I most interested in working with them? So if I'm interested, for example, in how various children with a variety of conditions or disabilities succeed in school, I may be more likely to look at school psychology, although that's not obviously universally the case, as evidenced by your research program at OU. But if you're ultimately thinking about practicing in schools, school psychology is most definitely the direction to be considering, as opposed to thinking about, I want to be primarily conducting research or practicing in clinic settings. I think that school psychologists at the doctoral level, depending on the training program they go through, have an opportunity potentially to be doing research and practicing outside of school settings. So, for example, from the Lehigh program, we have a number of our graduates who have ended up at academic health centers, including Nationwide. For example, we've got a couple of our graduates from the school psych program at Nationwide, as an example. That's not true of all school psych programs. So I think that this leads to another piece of advice would be, as you're considering training programs, you want to look at the outcomes of those programs. Where do the alumni end up working? How successful have they been in a variety of settings? And match that up with what your aspiration is. And the other thing, of course, is to look for the individual scholars with whom you want to work. Who's doing the research that you're most interested in? Who's doing the research that you want to gain the most experience from? And I certainly have had people apply to work with me at Lehigh who are not just applying to school psych programs, they're applying to work with folks in clinical child programs who do similar research to what I do, and vice versa. So I think the lines are getting blurred in some ways, and which is a good thing. But ultimately, I think what folks need to be thinking about is, what kind of career do they want to end up in terms of populations, settings, and so forth? Who do they want to work with to best match their research interests? And what are the outcomes of those training programs in terms of where the alumni end up, and the variety, let's say, of experiences, settings, and career trajectories that might be evidenced by the alumni in those various programs.
Thank you, George.
That was a really cool answer, and I saw one of us was typing up notes. Steve, could one of us ask that question again when we have Mark Wiest as a speaker?
Yeah.
And sort of I'm like, that's an evergreen question to keep coming back to. And as I think about the speaker series, like, you guys, as you're trying to figure out options, what you pick to do for graduate school or medical school is kind of a big deal. You're investing many years. And that's a question that would be worth sort of coming back to. With that as the plan, I'm like, okay, gang, let's make a Google Doc or a Google Sheet. I'm thinking like a table, and we can keep adding to it. So we heard this from one speaker. We got this from talking with Mark. George, listening to you, I was like, other things that I wouldn't have been thinking about as a student are like, would you rather do therapy or do you like doing assessment? If you really, really, really want to do therapy, that's your jam, consider social work, because that'll be the least other stuff to and school psych, you don't get the same opportunities to take classes or in the therapy part. But if you really, really like assessment, you're going to get better training and spend more of your time doing that. And if you want to do work with kids, but you love the idea of having summers off and you want to do it clinically, but not have to worry about research, school psych. I would massively upvote school psych, because working in schools, you get the summers off. So like a whole bunch of layers. Part of why it's salient to me is because my daughters are like starting to do the adulting thing. And so these are conversations I'm having with them. But really, really cool question and really cool answer. And I'm glad somebody wrote it down.
Yeah, thanks. And just to follow up on that, you make some good points there, Eric. I would qualify some of that though. So for example, the summers off thing. So school psychologists in most districts, at least that I'm familiar with, they do get a portion of the summer off, but a lot of school psychologists do end up doing gifted and talented assessments during the summer.
Yep.
And some other activities. It's obviously a lower intensity than
early
the
kindergarten.
Year. Yeah, but it's not it's not the complete summer. The other thing too is that I think there's variations by programs. There are some school psych programs that emphasize therapy more than others, and there are some school psych programs that are very assessment oriented, neuropsych assessment oriented, which is not our program. And also some programs like ours emphasize consultation as a delivery, important area of activity and delivery. So I think there's variation, around that. But you made some good points there in terms of some of the things that students would need to think about.
I appreciate that. And I was doing broad brushstrokes, and you're adding outstanding nuance.
We need to wrap up, but Julie, you had one last quick thing.
Just going to ask if George could take it one step further and help the students understand, is there a benefit to doing an EDSO for a master's within school psych, and what is that benefit?
Yeah. So real quickly, so everybody understands, most states certify school psychologists at the subdoctoral level. That can be a master's degree plus 30 credits. In Pennsylvania, we have something called an educational specialist degree, which is 66 credits. 3 years of graduate school, typically. About 2/3, if not 3/4 of school psychologists in the US are subdoctoral and operating, practicing primarily in schools, because there are limitations in most states for licensure, that you have to be at the doctoral level to be a licensed psychologist and engage in practice outside of, in this case, a school. I think that the way I've always talked to potential students about it is, you really know that you want to be a school psychologist, you want to operate in schools, you want to be primarily a practitioner, go to an EDS or a master's program, go to a NASP accredited, National Association of School Psychologists accredited program, and you can get out in your profession much quicker, 3 years typically. If you are interested in research as a potential career direction, and or if you are interested in potentially being licensed as a psychologist and or operating in other settings outside of schools, then the doctoral level is the way to go, for in terms of school psychology, at least.
Thank you very much, George. This was a great talk, and appreciated all the questions you asked and were asked and answered. We ended talking about disciplines, which is a nice segue. Next week, Dr. Andy Fry, who's a social worker who does treatment-related research, is going to be our guest on our speaker series. So I'm looking forward to that. And just end again by thanking you, George, and thanks to Eric and France for supporting putting this together.
Yeah, no, and I want to thank Steve and Fran and Eric for inviting me to be part of this, and to wish all of you good luck this summer. Again, you're engaged in two very exciting and competitive programs, and wish you all the best. And if anybody wants to reach out to me, I did provide my email address on that initial slide, and I can send it along to, or Steve, feel free to send it along to anybody who might want to follow up with me.
Happy to do that.
Thanks again.
Bye, everybody.